So long-term care, what you need to know. And certainly I may not cover everything, but I think that this will provide a lot of answers to some of the questions that you may have had in the past, and maybe provide a little clarification for you as well. So we'd like to figure out some of the answers to those common misconceptions about long-term care, recognize skilled care and other levels of care. We're going to talk a little about hospice. I was actually a hospice and palliative care certified nurse in my history as well, and enjoyed that. But there are a lot of common misconceptions about hospice, and hopefully this will clarify some of that. And talk about choosing a care facility. And we're going to touch on long-term care insurance. And I always say touch on that because it's the last thing in this presentation, but there are so many questions usually that brings up. And it always surprises me how many people have questions about long-term care insurance. If there's something else that you came here hoping to learn about today, by all means, share it. If there's something that I can, shed a little light on, I'm happy to. But I find that these are some of the main things that bring up a lot of questions for people. So some of the common misconceptions, I start off with the absolute number one misconception for everybody, hands down. Medicare pays for long-term care. Medicare does not pay for long-term care in any shape or form. Medicare does not pay for long-term care. And I stress this, and I know that there's a lot of confusion about it. And I know the premise of why there's some confusion about it. And I'll go on to clarify that, but just understand when I say Medicare doesn't pay for long-term care, this is absolute and completely how it is. Medicare is health insurance. And if you think about this logically, if, when you had children at home and say you had a 10-month-old, did you pick up the phone and call your healthcare insurance to tell them that you needed a babysitter? Of course you didn't, because they're your health insurance. Medicare is health insurance. It pays for health-related needs. Medicare doesn't pay for what's called custodial care. And when someone has chronic illnesses or disabilities, that is something that it moves on past a healthcare need, and it moves into what's called custodial care, the need for custodial care, similarly to what you would need in a 10-month-old who's unable to care for themselves on some level. They need some assistance in their activities of daily living. So Medicare does not pay for long-term care. That is all private pay. That's the big surprise for many people. And unfortunately, they don't find this out until it's too late sometimes. Another misconception, I can give away my property or move my assets to qualify for long-term care Medicaid when I'm ready to move to a nursing home. Well, while it's not illegal to ever move your property, move your assets, anything like that, it's not a legal issue. But if you wait to do that until you're ready to move to a nursing home, it's going to be too late to qualify for Medicaid. And the reason that I say that, Medicaid is administered by your state. So for Pat, who's in New York, the state of New York is going to administer the Medicaid program there, including long-term care Medicaid. For me, I'm in Louisiana, so my state administers it according to the Louisiana guidelines. So each state's going to be a little different. However, I can pretty well assure you that I'm not 100% sure that it's in every state, but I'd be willing to put money on it that it is. In each state, they have what's called a look back period. And in Louisiana, for instance, it's 5 years. So if I decided to move my large assets to maybe an adult child or a relative or a car, a house, whatever it is, to somebody, if they're going to go back when I apply for that long-term care Medicaid, and they're going to look to see what large assets have been moved in that look back period of 5 years. So whatever that look back period is in your state, they're going to look at what large assets have been moved, and that may disqualify you from qualifying for long-term care Medicaid. So your best bet is to always check and consult with an elder care attorney that plans for, just estate planning and things, but they can plan for long-term care. Just making sure that that attorney is someone that actually practices law in your state. And the reason that I stress that is, again, Medicaid is different for each state. It's administered by the state. So I know that some attorneys practice in different states. And if you live in an area like I do, I live in what's called the Arklatex. And although I'm in Louisiana, I'm just about maybe 10 or 12 miles from the Texas state line. And I'm also very close to Arkansas because I'm in the furthest northwest corner of Louisiana. So there are many attorneys who may practice in one state and not the other. So you just need to make sure that you get an attorney that is familiar with the law in your state. But if you will consult with them, they can help you plan ahead. If you have waited until the point that you need to move in or someone needs to move into a nursing home, it may be too late to qualify for Medicaid. Then it comes down to spending down until they qualify. So I like to kind of give that a heads up because those two things right there are huge issues when planning for long-term care. Another misconception, I can admit myself to any type of long-term care facility when I decide I want to go. And this is actually untrue. You have to qualify for whatever that facility provides. There are certain levels of care and you do have to qualify. Now, I know you may be thinking, well, I don't know anybody that's going to go pick me. I'm ready to move into the nursing home, but you might actually be quite surprised. There are many people who are ready to go to assisted living or nursing home care because, if nothing else, it may mean that they have 3 meals provided and they have the opportunity for some social activity when maybe they haven't had that at home and they have felt isolated. So there are some people who decide they want to go and maybe they don't qualify. So you do have to qualify for whatever level of care you're going into when you decide you're ready to go. Okay, so another misconception that's a big one is if I go into a skilled nursing facility or what we call a SNF for care, I will never return home. And this is untrue. The goal is if you go to a skilled nursing facility that you will return either home or to a lower level of care. Now, that doesn't always happen that way, but that's generally what the goal is. And we're going to talk really deeply about the skilled nursing facility because there's so much confusion tied to that. So we're going to go into that. So I also like to ask, what do you know about private sitters? Anybody had any experience in trying to hire or pay for private sitters? So private sitters are also private pay because they are considered custodial care. So again, regardless of whether that person is certified like a CNA or they're just your neighbor who does some private sitting, they are still private pay. And the only exception to any of these things when I say everything is private pay, it is private pay. If you do happen to have a long-term care insurance plan, you might be able to qualify for some reimbursement out of that long-term care insurance plan. But those are generally few and far between, and people in general, it's a minority of people who have those policies. They're very expensive. So in general, again, long-term care is all private pay. The only exception may be that you may qualify for some reimbursement if you have one of those long-term care plans. So I'm going to move right into talking about skilled nursing facilities because this is probably the biggest basis for some confusion when it comes to long-term care. So you could be admitted into a nursing home or a long-term care facility for a brief stay, which is called skilled care. And clarifying what that is sometimes so confusing for people. So this may raise some questions for you. If it does, throw your hand up, whatever, stop me and I will answer questions. But the confusion comes in that a skilled facility, a skilled unit is usually within a long-term care unit. And so over here, you have these skilled beds. And so here you have somebody receiving therapy for a broken hip. Here you have somebody that has the need for extended wound care. Here you maybe have somebody with a brand new feeding tube. Here's somebody who's had some falls and they need some therapy. And here's somebody who, I don't know, maybe they have been dehydrated, they've had some falls, maybe they have a fractured wrist, they can't go home yet, they need some therapy. So you have these people over here that just came out of the hospital, and these people have something in common. They have had a hospitalization for at least 3 midnights, and they have a need for some type of skilled nursing care or skilled therapies. And so all 5 of those people I just named, they're going to need something specialized from nurses and therapists, okay? Now over here, we have 5 people, and they're in the long-term care beds. So maybe they were in the skilled therapy or skilled unit for a while. Maybe they weren't, but they're over here because they require custodial care. Maybe they have congestive heart failure, chronic pneumonia, diabetes and heart disease, dementia. Maybe they have a combination of all those things, but these people don't have an acute need for skilled care. Now, these 10 rooms all look exactly the same, and they're in the same building. So no wonder it's confusing. Medicare pays for these 5 over here. Medicare doesn't pay for these 5 over here. So what happens is while somebody is in the skilled unit, there is a Medicare benefit to receive skilled care. And it runs up to 100 days. The first 20 days are generally paid for at 100%. And after that, you pay 20%. But while you are in skilled care receiving some specialized care for some specific need, Medicare will pay for this because it is still a healthcare issue. They're recovering from healthcare issues, and they require something that's above and beyond custodial care. So although it's confusing that over here in the building, these people are in the same identical looking room, these people are private pay, or their bed is paid for by long-term care Medicaid. And it's really, it's mind-boggling to some people because those rooms look the same. And, you know, legitimately they do. But over here, these beds are certified by the state as a skilled bed. So the majority of, you know, the big bucks, I should say, that go into a nursing home are made on that skilled unit. So they may have, say, 30 beds out of 130 beds, and the other 100 beds are long-term care. The largest income are going to be on these beds over here. That's just kind of insight into the administrative part. But understanding that once these days are up, or someone has plateaued in therapy, or they've maxed out their days, now they are ready to go home. Now, maybe home is back home to their house. Maybe home is to a new assisted living, or back to the assisted living. Maybe it's to independent living, or maybe they don't progress as well as they can to go home, and there's nobody to take care of them. So maybe this person has to come over here into a long-term care bed. Now, as soon as they move to this bed, they are private pay. Medicare is no longer in charge of their payment. They are private pay, and maybe they need to qualify for long-term care Medicaid. But as soon as they move from here to here, we are now in private pay. Now, the skilled benefits will renew each year. And so it's not to say that you can't have skilled care more than once. You can. I will also tell you that sometimes in some places, and I worked in a nursing home facility in administration in Florida for years. I'm actually from the beach in Florida. And over there, we had probably a 2-year waiting list for the facility that I worked at. Now, I will tell you this, because if you happen to be in one of those areas where there's a waiting list to get into facilities, there is kind of a backdoor way to get into a long-term care bed. And that would be is if for some reason while you're waiting on a bed, you have to go into the skilled unit. Of course, a facility is going to want to take these skilled people and move them to a long-term care bed because they're already within their building. They know them, they're familiar with them, the staff is familiar with them. So if you're waiting on a bed to come open in a facility, and in the meantime, mom falls and breaks a hip and she winds up in a skilled bed, she can probably get into that facility sooner because she's already in a skilled bed and can transfer to a long-term care bed. But really, the goal of those skilled patients is that they return home or go to a lesser level of care. That doesn't always happen, but sometimes it's not a bad thing when you've been waiting on that bed for, a year or whatever it is. So keep that in mind. If you are in one of those regions where there is, kind of a dire need for more beds in the long-term care facilities. The one thing that you do have to keep in mind is that in order to qualify for a skilled stay, you have to spend at least 3 consecutive nights in a hospital before you can discharge into a skilled nursing facility. So if you weren't aware of that, there may have been times in the past where you remember somebody in the hospital, and you commonly see it maybe with a fall, and maybe they're trying to find the root cause for the fall, but they can't really find anything. And so the doctor, after 2 days of running tests and things, the doctor says, let's just keep her for one more day. And I'm just going to check those kidneys again. They come up with something and you're thinking, well, you've done everything you can. I don't, we've kind of exhausted our options here. Why are you going to keep her another day? That doctor may actually have in mind that, just doing a little more digging and keeping them one more night, one more midnight will qualify them for getting some therapy that maybe they need. So sometimes a doctor might not tell you that, but that may be the ultimate goal they have in mind is, if mom was really just getting weak and you can see some muscle atrophy, that maybe they would qualify from having a skilled stay and having some intensive therapy. And so that may be in the back of their mind, whether they say it or not. So that you might have a light bulb going off now if you've ever had a situation like that and you're going, yeah, that happened. Now I get it. So you do have to have a 3 consecutive night hospitalization before discharging to that skilled unit. If you go home, that kind of ruins your chances for getting into a skilled stay. You have to go directly from one to the other. And I've talked about the Medicare coverage for that skilled stay. I do want to ask if anybody has questions about that, because generally it is the biggest source of confusion.
I have a question. If you're admitted to skilled care,
can you repeat that, because you were breaking up?
No,
I'm not understanding you because I think your internet might not be good.
You're still in it in December, but you also
I'm sorry, I'm not understanding. Am I the only one that doesn't understand? Okay. You might have to.
For start 100-day periods. Oh,
okay. I couldn't understand any of that, but I can kind of hear you now.
Is the 100 days per year?
Yes.
Or per term?
It's 100 days per year.
Okay.
Yeah. And so
Thank
it
you.
will renew, but it's per year. And a lot of those people do exhaust those 100 days. Did that answer your question?
Yes.
Okay, good. I just wanted to make sure I got it because you were breaking up really bad there at first. Sorry about that. Anybody else have any questions about that? All right, I'm going to move on. Okay, so you become a resident of the nursing home facility upon being discharged from skilled nursing care. And when you're remaining in that facility, this is basically the same thing that I said before. So as soon as you go from these 5 beds over here to over here, this is when custodial care begins. This is not custodial care. This is custodial care. And again, we talked about the Medicare coverage for a skilled nursing facility stay. So hopefully we've had a little clarification about that. So in the States, and when I'm talking about levels of care, I'm really referring to what's in the US because that's what I'm familiar with, having worked here my whole life. The levels of care are generally retirement home, independent living, assisted living, and nursing home care. These are the most common. There are certainly some other novel places in the States that you may not find everywhere, but you can find in certain regions. But these are the most common. And really and truly, retirement home and independent living are the same level of care. The only reason I have those separated, I know in my region, we have a retirement home, so to speak, that is just simply a freestanding building where people can downsize. They can go and live in their apartment. They have meals provided. They have some transportation to appointments and outings provided. It's great for socialization. They get to eat together. For me, that's a dream come true because I don't like to cook. So I'm thinking somebody's going to cook for me 3 times a day and activities, and I have friends. I'm like, hey, I got 2 thumbs up right there. So, I have no reason to dislike that at all. I think the biggest challenge is in downsizing. But understand that in that retirement home, you are independent. You are on your own. There's not necessarily a nurse in that building. There's not necessarily any type of aides or nursing assistants or anything that are kind of going to come help you with anything. You are independent. You have just downsized to a place where you don't have to cook. You don't have to pay utilities. You pay for that room and board. And there's probably managers that live in that building. And they certainly could help alert 911 if you needed it or something. But it may not be set up in a handicap format. It could be just about anything, but it kind of a downsizing situation where people can live independently, but in an area where they have a lot of peers that are in the same situation. And maybe they're just getting ready to transition down, they're trying to get rid of things before their kids have to go through everything. But truly, you're still independent. Now, independent living is really the same level of care. But I know that nowadays, with a lot of changes in healthcare facilities, and even here, we have independent living that is referred to as independent living because it is the first step in a continuing care situation. So you'll have a campus that has independent living, and then over here they have assisted living, and on the same campus they have a nursing home. So they have all 3 wrapped in one campus. And so there's kind of an easy transition, and you have some administration that kind of knows everybody and looks at everybody, and they can see when you need to transition maybe to the next level of care. So a retirement home may be singularly just a retirement home building. Independent living is really the same level of care, but I consider that a lot of the times in that continuing care campus that you're on. Now, assisted livings may be a freestanding assisted living that has no part in a continuing care environment. or it may be part of the continuing care environment. And again, meaning that someone's gone from independent to assisted and they're in between, not quite needing nursing home care. And in an assisted living, there may or may not be nurses there. They're not necessarily required. There may be some there part of the day and not others. Assisted living does not mean that someone is going to bring you your medicines. It does not mean that anybody is going to assist you unless you have a specific need. And usually, and understanding all the assisted livings are set up a little bit different, but many of them will charge a different level of care depending on how many activities of daily living you need assistance with. And so you say, well, what are activities of daily living? Activities of daily living, or ADLs, are those things that we all do every day, like dressing, bathing, ambulating, mobility, transferring, toileting, hygiene, that kind of thing. We do these things every day. So those are our activities of daily living, or ADLs. So say someone needs assistance with 2 activities of daily living. Maybe they need assistance for safety to get in and out of the shower and take a shower safely. And maybe they need assistance getting into their bed at night because maybe they've had a fall from the bed and maybe it's just difficult to get into for whatever reason. So if they need assistance with 2 activities of daily living, they're probably charged accordingly, according to some plan or some level. It just depends on the facility. But assisted livings, again, they don't provide medicines. Usually, they will have either a place you can contract with that comes into their building if you need assistance. Maybe somebody has some cognition issues, some cognitive deficits. Maybe they have a little bit of dementia, but they're pretty high functioning, but they just can't get their medicine straight. Maybe they have a lot of them. You can possibly contract with an outside agency to provide medicines safely and routinely each time they're due. But the facility itself does not keep medicines. It's not like a nursing home where that's the job of the nurse. And now again, moving into nursing home care, it is part of and standard that there are nurses 24 hours a day, and they routinely administer and keep all of the medicines that are given to the residents there. That is part of the routine care and what's paid for nursing home care. Those are pretty much the levels and some of the main differences. There's going to be some other little differences, and you're going to find differences in each facility because each one's going to have their own little draw on what's going to bring you in. Oh, ours is better because we allow your pet, or, you know, ours is better because we have pink walls instead of yellow like down the street. They're all going to have their own little things, and you're going to find that out. But we're going to talk a little more about some of the things also that you might be surprised at that are not included in your bill. And again, all of those options up there are private pay. So you pay for all of those options. If you apply and qualify for long-term care Medicaid, the only one of those options that will pay, that can be paid for by long-term care Medicaid, is nursing home care. The assisted livings and the independent livings, retirement homes, are all strictly private pay. So I'm going to talk a little about hospice. And again, I worked as a hospice nurse for many years and absolutely loved it. Hospice is a very unique benefit. It is a Medicare benefit. So this is one of those things that people overlook a lot because it is a Medicare benefit. It's very underutilized. Probably used only about 10% of the time. It could be used a lot more. And if you are familiar with some of the things that hospice provides in the way of services, it's really unique. You're not going to find anything else like it. You can receive hospice services, whether you're at home, whether you're in the nursing home. Some hospitals have a unit specifically designated for hospice and palliative care patients. And some areas do have inpatient hospice beds where it's a hospice inpatient facility. In our area, we don't have enough of those beds. So we oftentimes have people dying at home in the surrounding areas, in the rural areas, because they're not able to get into the facility. They die waiting at home. However, you can receive hospice benefits wherever you are. Hospice benefits, again, are available under Medicare, and they are reserved for those who have a terminal diagnosis. Now, does that mean that they're ready to die in a week? Not necessarily. There's some misconception about that. But there are guidelines and requirements, and you have to qualify under those. And you can always have hospice ordered to evaluate by a primary care doctor or whoever is seeing the person. They can order hospice to evaluate for admission, and they can decide what is available, what options are available, what they might be able to admit someone for, or if they can't, or maybe they can reevaluate a month later. However, there are many times that people can be deemed terminally ill. For instance, there are lung cancers that are, not a fast growing, but if somebody has opted to do palliative care only, and they don't want any aggressive care, they may certainly qualify for hospice benefits. And with hospice, as opposed to home health, hospice is being able to choose how you spend your remaining time. With home health is a Medicare benefit, but home health has to serve those who are limited really to leaving their home only on certain times because it's made difficult to get out maybe to the doctor or to outpatient therapies and things. With hospice, you're not limited to being at home. Hospice benefits want to enable you to go and do whatever it is that you want to do for as long as you can. So you get to choose how you live life. So for instance, if you have someone who maybe has a lung cancer and maybe they're on oxygen, or maybe they have some heart disease or lung disease, and they are on hospice for that, and they're requiring oxygen, but they want to go visit their family. They live in Louisiana and they want to go to North Carolina to visit their family. Hospice can even help arrange making sure that there are things in place wherever they go to, so that if they need oxygen, if they need refills or whatever it is that they need, they can get them while they're there, while remaining on hospice services right in Louisiana. So hospice services do so much. They also have a multidisciplinary team, meaning it's not just a nurse, it's not just a doctor, but they may also have a doctor or a nurse practitioner or a PA that comes and sees that person at home. The nurses will visit at home. It keeps you from having to go out to the doctor. They also have chaplains, they have social workers, they have some type of aid that can come help with bathing or things like that if it's needed. Maybe those things aren't needed at first, but you can always get those things added. Also, there's a very unique benefit for hospice that allows for some respite care, and some agencies can offer the primary caregiver some respite time while someone from the hospice stays there with that person who's on service, and allows that caregiver to get away for a little while and take that time that's needed to care for themselves. So these are really, they're benefits that are not widely known. One other very unique thing is, because this is, really a benefit for those who are terminally ill, after that person dies, there are staff from the hospice that will reach out to the remaining loved ones and for up to a year to make sure that they are getting what they need, that the grieving is going appropriately. And if they are in need of other referrals for outside support groups or anything like that, it's recognized and they can help them get the services that they need. So hospice is a benefit. It's the only unique benefit that actually provides some services for the loved ones as well. Just to throw this in as well, probably little known, is if someone is put on service, let's say that they are put on service for end-stage heart disease. The medicines that are associated with end-stage heart disease are free. They are provided by the hospice ongoing, and they are at no cost to that person. So that means you don't have to pick them up. You don't have to pay for them. They're delivered to the house. They can be ordered on the spot when the hospice staff knows that they're needed. This is not only a unique benefit, but it provides the opportunity for the hospice nurses to evaluate somebody and order some unique medicines that most doctors are not aware even exist. Maybe they're compounded medicines. So if you have somebody on end-stage heart disease and you can see that struggle for breathing is creating a lot of anxiety for someone and making it very difficult to be comfortable, a hospice nurse may know that there is some inhaled morphine that would be the best medicine to help this person breathe. And if you are not familiar with that, most doctors wouldn't even know that that exists. I can't begin to tell you how many times in my past I had to give specific instructions to physicians on how to write prescriptions because they had absolutely no idea, because it was not something that they usually work with or that they know is available. But if you have a good compounding pharmacy available, your hospice nurse is probably in tune with what can be done and offer a lot more relief than your standard primary care physician. So you do have to keep that in mind, because it enables people to live a lot more comfortably and spend their time how they want to in their last days, months, weeks, sometimes even years. I will also mention that there are people at times who manage to get on hospice. They begin to thrive on hospice with all the TLC that they get, and they actually have to be graduated off of hospice because they do so well. And so, and when they lose that little bit of TLC that they're getting from the hospice staff, they tend to turn around and decline again. And so then they're readmitted. So this does happen. It's not out of the question. But I hope that you all have had the opportunity to have some type of good experience with hospice, because it generally is a really good, positive experience for anyone who has had the opportunity to see what they're about. Any questions there? That usually brings up some questions as well. All right, I'm going to move on. So how do I choose? Well, your decision-making process is going to have to be guided by the level of need of the patient, because again, you have to qualify for whatever level you're going into. And again, each facility is unique. Some have wallpapers, some allow animals, some don't. You're really going to have to match the person's interests and their preferences. If you do have a facility that allows cats and you're allergic to cats, that might not be the place for you. Some are really simple decisions. You can also find resources online that are helpful in locating nursing homes. And in your community, you can put in a zip code. If you go to medicare.gov, you can go with the locator services, put in a zip code. You can look at their 5-star rating system. That is based on the state surveyor's visits to the facilities. How can I be sure it's the right choice? Well, you do your homework first. I will share with you as well. I do a class on how to pick a nursing home, like the homework that you need to do, and basically talk about some of the red flags of inadequate care and what the state surveyors look at and how to interpret a state survey. I invite you to that class if you're talking about or considering putting someone in a nursing home. It will provide you a little better insight into what to look for in looking at that nursing home. And we go a little more into that 5-star rating system as well. So you really have to do your homework before you make that decision. If you are able to go in and tour a facility, always a good idea. I know with COVID recently, it's been a little bit more difficult, and the whole situation with long-term care facilities has been really out of sorts a little bit, to say the least. I think things are kind of returning to somewhat a sense of normalcy now. So hopefully you could go in and tour a facility before making a final decision about them, whether it be a retirement home, nursing home, or anything in between. This is a site. Visit the American Council on Aging for a free online pre-screening eligibility for long-term care Medicaid. If you go to that website and you're considering whether you might be eligible or someone might be eligible for long-term care Medicaid, you can go to that site and it will give you kind of a little free pre-test. Doesn't cost anything at all, and it's not 100%, but it certainly doesn't hurt to take that eligibility test. So I would invite you to do that. So long-term care insurance, these are policies that some people opt to purchase, usually when they're a little younger, and they can possibly make claims when they need them for providing something for custodial care. They might be able to get some reimbursement for paying for custodial care. These policies are usually very expensive. People pay into them for some years, and they hopefully will make a claim when it's appropriate to do so. The most of the time, I find that people wait until much later when they could have been making claims, and they don't do that. The reason that I say that, I am myself contracted with several companies to do assessments, claims assessments, people applying for long-term care, and benefits assessments, claims assessments for long-term care insurance companies. I don't work for any of the insurance companies, so I don't have a dog in that hunt, but I do work for some companies that are a third party. And so I hear a lot of what people have done, how long they've waited to make claims. And unfortunately, I would have to say that the majority of the time people wait until they could have been making claims and they don't. Sometimes it's hard to get those claims started. You kind of have to dig your heels in and be a bulldog, or have someone that is able to talk to that company on your behalf that will dig their heels in and be relentless in the fight to get that claim started. Because insurance companies are successful for one reason: they make money. And I can say that because that's how any business is successful, is they make money. And the less money that they have to give back, then the more successful that they are. This is common sense. So they're probably going to do everything they can to not give money easily. But if you have someone who has decided to be that bulldog on your behalf, then hopefully they can, be able to retain or get back some of that money that you've put into that policy. Because again, these are very expensive policies. Now, the one thing that I do have to say, and I find it extremely important, probably more so than most things, if you have today one of these long-term care insurance policies, if you yourself have one, before this day ends, you need to make sure that someone else knows that you have this policy and that they have the information and permission to talk to the insurance company on your behalf. Because what often happens is people don't use this policy because maybe they have an accident, or they're diagnosed with some cognitive deficits like dementia or a head injury. Maybe they're not able to make the claims on their own. If nobody else has permission to talk to that insurance company, or they're not aware you have that policy or the information of how to get in touch with them, nobody is going to be able to make a claim on your behalf. So if you are one of those people that have one of these policies today, you need to get that policy out, all the information, and get in touch with that company and make sure that there is permission for them to disclose information to someone on your behalf, and vice versa, or they will make it impossible for you to make a claim. So I stress that. You'd be surprised how many people overlook that, and then they're not able to use their policy. It sits with all that money invested in it, and it goes unused for the entirety of its existence. So does anyone know about your policy? Ask yourself that question. Any questions about long-term care insurance?
Okay. I have it. I paid into it for years, and then you get to the point that you think, I paid more into it than I'll ever get out, but I've invested so much in it at this point that it's crazy it's like a catch-22. But I didn't realize that I had to let them know that that they could talk to my family about it. So thank you
Yes.
for that.
Yes, if you have anything healthcare related, there is nobody in the world that's going to talk to you because of HIPAA. So keep that in mind, that you will have to designate someone who can talk on your behalf. And back to what you said about, yes, I've invested so much, it's hard to say I don't want it anymore. But I hear that constantly. And you're very fortunate if you have it. And some of these policies do have even a benefit that you can reclaim some of the money, even if you're in a hospitalized situation. A few of them do. And there's a few of them now that if you never use the insurance, that you can have a loved one that might be able to draw some of the money out. So that is available in some rare cases as well. And that's a pretty good deal because you can get some of that money back for a loved one later. But yes, make sure that you have someone designated that can talk, and that person's got to have all your information to talk to them too. They need the policy information, the number, the phone number. You need to give them everything so that they have that readily available in the case that you can't make a claim for yourself.
Now, would that be covered by my healthcare proxy or no?
It could be, but you need to look into the specifics. And they need to have a copy of that healthcare proxy. Your insurance company is going to have a copy of that. And I would go ahead and sign all the releases that you can, just to make sure, because if there's any way that they can make it more difficult, they will. And I hate to say that. I don't like to be the negative Nancy, but you know, I'm just telling you that if you consider the worst case scenario, you want to make sure that you've made every route possible that someone can speak on your behalf, or consider that it could be very difficult to make that happen.
Yeah. Okay. Thank you.
Yes. Anybody else have questions about that? All right. Hopefully you can have an easier time in looking at your options for long-term care with some of this information, but it is, no matter what level you're going to, it really is one of those jobs that requires appropriate research. And unfortunately, many of us wait until we're in a position we have to make a decision, and we don't get time to do the appropriate research. So if you're here today, I hope that you are in a position where you're planning ahead. I always like to hear that. But that research is really vital to your choices. I also stress again, if you are doing long-term care planning ahead of time, I would highly recommend that you get an elder care attorney, somebody that can do estate planning and things like that, because they're going to be the most helpful in your particular state, because the laws are so different from state to state. So I would highly advise that you consult with someone that can tell you the best way to plan for the future financially. And then if you need more information about the particulars about choosing facilities, these classes are really great for that. Again, I invite you to the Choosing a Nursing Home class as well, because it can provide some options. Just on a side note, we're also going to have a class starting about caregiving and the dying process. So that is also going to be something really, I think, to provide a little comfort for those who have never been with someone during the dying process. It can be, I think, very stressful for some who are anticipating one thing and it doesn't happen that way. It might prepare you for some things a little better. And by all means, if you can share this information with someone else that might need it, we all appreciate it. It gets set up, refer them to the class, come back with them and take it again. And you can share it on social media. You can also keep this conversation going in the lounge after the class and find related classes by clicking